same thing. So you're talking about all of these studies from the 1900s, and then now into 2025, it's still showing the same thing. So deep pockets, 6 millimeters or more, were harder to treat, only about 16% closed. And we're dealing with specifically maxillary molars are harder to treat blind than other teeth. So traditional non-surgical scaling and root planing is most effective in shallow pockets, and shallow means clean. So all the evidence out there intended to arrest and control periodontitis, it all depends on effective root debridement. So that even means for doctors that are using like the Lanap laser, any type of laser surgery, it's still a blind debridement. So it's really important. Lasers don't vaporize calculus off. Lasers don't disinfect calculus. Everything depends on effective root debridement. So what that means is any adjunctive therapy, no matter what you do, if you don't get the root completely clean, it's not going to work. It may temporarily work. So if you're placing a resin or using lasers, the patient might look good at their next visit, but then eventually, and it happens very quickly, they do relapse. Why is that? Tooth and root anatomy, I always say, we learn root anatomy in hygiene school, but not every tooth is the same on every patient. And when I go in there with the endoscope, I see the craziest concavities, grooves, pits, crown margins, difficult furcations. Not everyone's second molar looks the same. Not everyone's canines look the same. So really, we treat patients how we think we know what tooth anatomy looks like, but once you actually get in there and see, every patient is different. Then you have gum tissue thickness. Smokers have very tight, thick gum tissue. It's harder to get in there. Operator training experience, but the most important factor is lack of visibility. So for all these years, like I said, there's been a major disconnect. So we do blind scaling and root planing. If that doesn't work, then the patient is having surgery. And what happens if maybe they can't afford surgery or they have medical problems, so it's contraindicated to have surgery? Then what do we do, right? There's never been an in-between procedure, and that's where the dental endoscope comes in. Or maybe they've had surgery in the past and they had a terrible experience and they refuse to have it again. Or maybe I have a lot of patients that I retreat after the Lanap surgery that have residual calculus left behind. So all the ways that we've been traditionally diagnosing, we take full mouth series, we take pans, we take cone beams, we do full mouth perio charting, visualizing with or without loops, and we rely on our tactile detection. And when we do that, when we talk to the patient, and I've been guilty of this myself, but we say things like, you have a little bit of bleeding, you have a little bit of bone loss, you may have some gingivitis. Let's watch. I hate the word watch, but everyone says it. And we're downplaying what's going on to the patient. So I like to talk about minimizing or minimizing language. It's easier for the patient to understand the severity of the issue if they see that it's something is actively happening. Really, really important. And from my experience with the endoscope, if the patient has blind scaling and root planing, there's a spot that's bleeding, it's bleeding because there's something that is still there. How often are you taking radiographs? So I take radiographs personally once a year. I take PAs of implants once a year, but I'm always taking vertical bite wings. As you can see in this example, you can't see the height of the bone on a horizontal bite wing. So I'm very big on vertical bite wings. Radiographs of implants. Sometimes you can't rely on a PA. Sometimes, depending on the angle of the implant, you can't always get a perfect PA of an implant. So you can see it's in the image on the left, the threads aren't parallel with the x-ray. So you really can't then determine how much bone loss is around that implant. It's really important to get a good x-ray of an implant so you can count the threads and monitor the bone loss. So this is not an acceptable x-ray. I mean, sometimes you can't always get the apex, but to try to get the apex at least, and you can see the angle of the threads is also off. So this was one of my cases. For time's sake, I'm just going to go through this quickly, but whenever I show this x-ray, I ask everyone, do you see cement on this implant? Most people say they don't see cement on this implant. So this implant was placed by my boss, and what we do is after they get the implant restored by their general dentist, the patient comes back in, the assistant takes a PA to make sure that everything is seated properly, that there's no excess cement, and as long as everything looks good, we send them on their way. So my boss looked at this. He said it looked great. You're seeing Kristen in a few weeks for a cleaning. So the patient came in, she was due for vertical bite wings, and this is what I saw. So because it's a different angle, right? Even on the previous X-ray, the threads look good. The threads look like they're parallel to the X-ray. But then when I took my bite wings, there was a big piece of cement on the mesial. Now that you know it's there, you look on the mesial and you can actually see it. So this is a new implant, a new crown. What do? We go in with the endoscope because you don't want to over instrument on an implant. But if we let that cement there, then the patient would eventually get periimplantitis. So when I go in with the endoscope, I can see the cement, remove it, and I don't have to stay there too long wondering if I'm getting it all out. But without the endoscope, we also can't guarantee that I got it all out. So instrumenting around implants is difficult. It's not like a natural tooth. We can't actually even feel if there's Burnage calculus always on a natural tooth, but implants, you don't ever know what type of threads you're dealing with. So it's very difficult to clean and they're never going to feel smooth. So the reality is this is how we treat patients. We treat them blind. I use the analogy of blind scaling and root planing is like driving in the dark without your headlights on. You can't see anything. So we're going in there and we're relying on our tactile detection to really feel. So why is visibility important? If you can see it, you can treat it. So this is what the endoscope looks like. The top part is a computer monitor all in one. It's medical grade, it's touchscreen. You can record pictures and videos, which I will show you guys. The camera is a high def 160K digital camera. It's equivalent to like a 4K TV, and it is 100 times magnification. The camera sits in 4 explorers, which allows you to gain access to the pocket. The system control unit is the light blue part that's below the monitor, and that's how you control the light. So if I'm treating an implant and there's like a reflection from the titanium, I'll turn my brightness down. And if I'm treating a natural tooth, then I'll turn the brightness up. And then what everyone always says is like, how do you see with all the blood, plaque floating around? Well, there is a water portion to the endoscope. So you either have a water bottle that sits on the unit, or you can just plug it directly into your chair, and the water actually comes out of the tip of the camera. And then there's a foot pedal to control that water. So just like we have different terms in dentistry, like LANAP, we have pinhole, we're calling this periodontal endoscopic therapy or PET. And we want this to be the next thing that patients search for. So it's a miniaturized digital video technology that enables us to diagnose and treat areas below the gum line without the inconvenience and discomfort of conventional surgery. So the camera never comes in contact with the patient's saliva. How is that? There's a disposable sheath or cover that goes over the camera. This is what the end of the sheath looks like. So there's a little metal tubing that's like a housing for the camera. And then at the end, you can see in this photo, there's a little lens on the end of it. And the camera is going right up to that lens. And then that's what's going into the Explorer and then into the pocket. So this is just a picture on the left. You can see that the camera is getting fed through the sheath. Once it's in on the top right picture, you can see that's one of the explorers, and that's the camera being inserted into the explorer. You can see the tip of that is illuminated because that's where the camera is and the camera is on. And then in the lower right picture, that's the camera being inserted into the explorer. I'll show you a side view, but notice in that bottom picture, the tip of the camera stops like halfway through the Explorer, and then the Explorer looks like a triangle metal piece below the camera. That is done purposely. The back of the Explorer is all metal, and that's what's deflecting the gum tissue out of the way, and then the camera is protected that way as well. So then the camera part where the Explorer is open, that's what's facing the tooth, so you can see. So these are the 4 explorers it comes with. These can be put in the mealy, the ultrasonic. They are sterilized. The only disposable piece is the sheath. So the covering over the camera, that gets thrown out after each patient. So the explorers, you use all 4 per quadrant. They are area specific. So the double banded ones, it's hard to see in a picture, but the 2 double banded ones are for the distal surfaces and they look like your 1718. And then the single banded ones are more straight. Those are for the buccal into the mesial and lingual into the mesial. So this is a video on what it looks like while I'm working. A lot of people say, well, where does this sit in relation to where you're sitting? So right below my hands is my patient's head. So basically, I'm right-handed. The unit is sitting right on the other side of my patient, so I can easily lift my left hand up. And you can see there's little buttons on that left hand side. So there's a camera button. When I tap that, it takes like a screenshot or a still image. The red circle is how I start recording a video. And then once I start recording, it turns gray. And then the circle with the square below it will illuminate. And then I press that to stop. Everything gets stored in a HIPAA compliant folder, so there's no patient's name. It will just have the date and the time. And then I will look at my schedule and I'll know exactly who I was treating at that time. So this is that side view that I was talking about. So you can see that the tip of the Explorer extends beyond the camera. So just like when you're probing, and you probe until you get resistance, you're doing the same thing with the Explorer. So you're putting that Explorer in until you get resistance. And although the camera is not at the tip, it's still showing the entire pocket. So the camera is relaying the image of plaque and tartar below the gum in live time. So you're watching yourself remove the calculus. It could be used by a dentist, a periodontist, hygienist. There is no assistant required. People ask me this all the time. If they need an assistant, the assistants actually get in my way. The reason for that is because there's too much going on. I'm not holding a mirror in my non-dominant hand, I'm holding the camera and I'm moving it in all different angles to be able to see. Plus, if the assistant was suctioning, they're pulling the water out from where I need it. So you have your water from your ultrasonic and then you have your water from the endoscope. And I need all that water in the pocket to flush out everything in there. Otherwise, I wouldn't be able to see. So when an assistant suctions very close to where I'm working, it pulls the water out of the pocket and it makes the image extremely blurry. Everyone always asks me this, how do you code? How do you charge the patient for this? I basically use very easy numbers. So on Long Island, our fees for the laser surgery are roughly 10,000. We're charging the patient 5,000 for the endoscope, and then blind scaling and root planing is about $2,000. So if you work in a fee-for-service practice, we're coding this out as scaling and root planing, and then we're adding on an unspecified fee, which is just $4,999. The goal is always half of osseous surgery or LANAP surgery. Patients don't hesitate to pay that because either they've had surgery before or they don't want surgery. So this is still saving them a significant amount of money, still getting really great results. We combine this with LANAP laser. So when doctors are doing that, they're coding out 4261 or 4262, and they code the same for that. And then I'm using the endoscope to do the cleaning part of the LANAP surgery. If you're combining it with biologics like Emdogain or Gem 21, you can code 4240 with 4265, and I'll get into biologics. Another question I always get asked is how long does this take? I usually do half the mouth at a time. I've become very efficient over the years. It takes me about an hour and a half to do half the mouth. Sometimes it takes me 2 hours. It really depends. A lot of it is patient management rather than technique. I had a patient Wednesday morning who was choking on the water. He was choking on his saliva. And then you have double the amount of water. So he was extremely difficult. He wouldn't stay open. I do use the relief suction and then I use the slow speed on the other side. I don't like the Isolite or the Isovac. There's too much in the mouth at once, so the relief is very, very small. But even with both of those in, he was still choking. So it really just depends on the patient. The patients that are easy to work on, it's a very easy, quick procedure. Sedation, I have some patients that want nitrous. We don't do oral sedation. Some practices do. Definitely local anesthesia. When you have the Explorer and your ultrasonic in the pocket at the same time, they definitely feel it. So a lot of people say, well, I've never heard of this before. Is this a new technology? Well, it's been around for 30 years. So Dr. John Kwan is the periodontist in this picture on the left. He's from California, and he invented the perioscopy, which was one of the first dental endoscopes to come out. He then sold to Zest Dental, which they sell implants, and they kind of just kept the perioscopy in a warehouse. They didn't market it, so if people inquired, they would sell them here and there. But that's why no one really knows about this technology because no company really marketed it. Then Dr. Aziz Borer on the right, he is the founder and CEO of PerioView. And I met him at the AAP meeting a few years ago. And we bonded because he combines his laser surgeries with the endoscope. And I said, oh my gosh, I do that in New York. I've never met anyone else to do that. And I always felt so alone in my dental endoscope community because there's not a lot of us. So we connected and I said, if you start your own company, reach out to me. And that's kind of how I became a trainer for them. So this is the evolution of it. So all the way on the left, you have the DV1. You really couldn't see anything on this unit. Then the next one is called the DV2. I actually have used that unit before. Then you have the perioscopy. This was like a small 6 by 6 inch circle and it only magnified about 30 to 40 times. And then you have the PerioView, which is a bigger 11 by 11 inch monitor and 100 times magnification. So that's another reason why the technology never took off was because it was very difficult to see. And hygienists were like, I don't know what I'm seeing, so I don't know what I'm doing. So this is just like a side by side of all the units and how they've evolved. These are all turned on. And this is an extracted canine with calculus. So you can see the image quality has progressed over the years. And now it's much easier to know what you're looking at. So when I'm using this, I'm pretty much always going in to see calculus to treat, gum disease, but occasionally I'll go in there to diagnose a root fracture. And when I'm in there removing calculus, sometimes I see a surprise root fracture. I will see overhangs. I will see subgingival caries, especially around old PFMs. You can't see that decay on an X-ray sometimes. You'll see it with the endoscope first. I see gutta percha perforation. I see external root resorption, excess cement, root anatomy. Interesting root anatomy where if I was scaling blindly, I would probably over instrument because it feels rough, but I'm not seeing anything. Implant threads, cemento enamel projections, and also cemental tears. And when I talk about this slide, I end with cemental tears because most people don't know what a cemental tear is. And a cemental tear is a fragment of cementin. And you may have seen this and may have not known what it is, but it's a jagged piece you can see on the mesial of number 9. It's a piece of cementum that flakes off from excessive occlusal forces. So why is that so important to remove? Well, if you leave it there, it's going to trap plaque and bacteria, it causes vertical defects, and if you don't take care of it, it's going to cause a big problem. So this is a video of the cemental tear being removed. So cemental tears, a lot of times doctors will flap that area open to remove it, but it actually comes off just like calculus comes off. So to orient you before I play this video, there is a metal looking piece on the lower left hand of the screen. That is the explorer deflecting the gum tissue out of the way. You're always going to see some gum tissue that's like that pink blob that you see right here. You have the root of the tooth on the upper right-hand corner, and between the gum tissue and the root, you see a more whitish looking piece. That is the actual cemental tear. So when I play the video, there's water going on, so that's why you see the tissue and blood moving. And then I'm just going in there with a piezo to remove it. So it comes off just like calculus comes off. I will show you guys calculus videos later on. But why is this so important? Because this is all preventable. You don't need surgery for this. It comes off like calculus. And a lot of times these are misdiagnosed, they're underdiagnosed, and a lot of people don't know what they actually are. So cemental tears, I say this is a new dilemma. I've seen like an uptick in cemental tears since COVID. My own personal opinion, I think COVID stressed a lot of people out. More and more people are grinding and clenching. I see them often. So you can see in these red circles, those are all what cemental tears look like. Not to be confused with calculus. Calculus looks more like a triangular piece sticking off the tooth. This was a case we had, looks very interesting from 2019 to 2022. It looked normal in 2019, and then that piece actually completely came off the tooth, so it wasn't even attached to the tooth anymore. So my boss sent it out, and sure enough, it came back as a fragment of cementum. So it was a cemental tear. So ways to use the dental endoscope. So we do sometimes periodontal endoscopic therapy by itself. We'll combine it with biologic modifiers. We use it in combination with the lasers. And also sometimes I'm going in on a single tooth just for diagnostic purposes. So a common question I always get asked, well, how do you choose which one you do? So if the patient is stage 1 and 2 and they have mostly horizontal bone loss, I'm just using the endoscope by itself. That doesn't mean that for stage 3 and 4, I don't use it by itself, but usually we'll combine it then with biologics or laser because they have vertical defects. But if the patient can't afford surgery, I'm using the endoscope by itself in those stage 3s and 4s. So this was a study that came out in 2024. There's not a lot of research on dental endoscopes just because there's lack of users, lack of endoscopes in universities and colleges. But this study came out and it compared endoscopy to flap surgery, specifically in intrabony defects. So the conclusion was that flap surgery had the same results as dental endoscopy. So I like to talk about implants. Periimplantitis is still a mystery. Everyone treats it differently, but I want to talk about it because of what I've seen in implant threads. So LAPIP stands for laser assisted peri-implant procedure. It's just like LANAP, you're just doing it around an implant. So their protocol is you see bone loss around an implant, right? You're probing. The laser is vaporizing the bacteria, the diseased tissue. You're going in there blindly, you're scaling it out. The bone is modified. You're going around the laser a second time. It creates a clot, and then it has to heal for 9 months to a year. So you can't probe or go below the gum line for that long. Then usually there's an occlusal adjustment, and it does work. I have seen it work, but LAPIP, just like other laser surgeries, it's still a blind debridement. And these are pictures of implants that I took. So you can see that there is calculus between those threads. Like I said earlier, you cannot feel if that's off. I can spend an entire hour scaling an implant because it is so difficult, so tedious to go thread by thread and really get that all clean. So this was a laser case that I did with my boss. He actually had treated the left X-ray first with just the laser and it didn't work. So then I went in there and we combined the laser with the PerioView, and you can see that the bone started to fill in just after 3 months. And this was another case that was treated by itself with the laser. It didn't work. And then we retreated it with the endoscope. So then after we started to see these results, we just started doing every single LANAP and LAPIP case with the endoscope to get more predictable results. So I'm going to go through this very quickly. Biologic modifiers, you guys may have heard of Gem 21 and Emdogain, but Gem 21 is an enamel matrix and it enhances the patient's natural ability to heal and restore bone. Comes in a syringe. Emdogain is more popular. Straumann makes it. It comes with Pref gel and then actually the Emdogain. So you put the Pref gel in first and then you're placing the Emdogain second. Pref gel is an EDTA. If you've not heard of that, it's basically like an acid etch and it's removing the smear layer from the root, preparing it for the Emdogain, preparing the tooth to regenerate bone. So the smear layer, after we do all of our instrumentation, there's always a smear layer on that tooth, and it's a thin amorphous layer of organic and inorganic debris that forms on the surface of the dentin and in the dentinal tubules. So it's really important to kill that bacteria to promote healing. So these are what they look like. Emdogain flapless is being advertised in Europe. It's just not yet here yet. But mostly Emdogain and Gem 21 are used during surgery, but they can be used flaplessly as well. Hygienists cannot place that. I always just like to add that in. They have to be placed by a dentist. And these are just two cases that I wanted to show you guys that were done with no biologics, no laser. This was just bone that regenerated because I got the root totally clean. So the mesial of 11, this gentleman was commuting to the city before COVID, And he was seeing a periodontist there after work, and then he started working remote when COVID happened. So I started seeing him on Long Island. He had scaling root planing, osseous, LNAP, and he still had some isolated defects. So there was a 12 millimeter pocket on the mesial of number 11. Went in there with the endoscope, and there was burnish calculus at the base of that pocket. So I cleaned it out, and then this x-ray was taken 2 months later, and you can see that the bone filled in. So they don't tell you this in hygiene school, but hygienists can regenerate bone as well. This is a perfect example that you get the root clean and the body heals. This was another case. The patient came in because his dentist was doing all new upper anterior crowns, and my boss didn't want to do anything that was not conservative in this area because it's in the aesthetic zone. So I treated the mesial of 8 with the endoscope. He got new crowns, and this was also, I always take x-rays 2 months after I treat the patients. This was 2 months later, and you can see that that defect filled in, and the patient got his crowns, no recession in that area. So I have thoughts on adjunct therapy. I'm not a believer in a rest-in, but if I do use adjunctive therapy, I'm using the endoscope or I'm using perio-DT or combining the two. So as I talked about the smear layer earlier, perio-DT is desiccation therapy. Hybenex is also another brand that is out there, but it's basically taking the water out of the calculus and it's making it flake off the tooth, making it easier to remove. It's also killing the bacteria and removing that smear layer. So I'm just going to go through this very quickly, but this was a study done that the bacteria that causes periodontal disease, they did blind scaling and root planing without perio-DT, and then they did blind scaling and root planing with perio-DT. With perio-DT is the blue line, and you can see that even after an entire year, the bad bacteria that causes periodontal disease is still basically undetectable. So if I am using an adjunct, because sometimes I still do blind scalings, I'm using perio-DT with it. So problems with adjunctive therapy, like subgingival irrigation, arrest and lasers, perioprotect trays, if you don't get the calculus out, it's not going to work. And as you saw from those two x-ray cases, if you do get the calculus out, you really don't need adjunctive therapy. So everyone says to me, well, what tips do you use? So I use Acteon. I don't like the Cavitron. The tips are too short for me to treat a periodontal patient. But again, I'm going to quickly go through this. The 10Z is my go-to. There are probe markings on there, which I love to use with the endoscope so I can kind of see how deep I'm going in the pocket. It's also very skinny. I can really get in there around the camera. And then I love their periodontal tips. So they have rights and lefts that are extremely long. They help me get into furcations, the distals of second molars. But one thing that I really love is they have implant protect tips. So it's the only piezo company out there that has pure titanium tips, and they are extremely, extremely skinny, and I'm able to go thread by thread to get in there. So I have a comparison, and these are Cavitron tips. You can see they're very short. Their rights and lefts are very short. They also have a Cavitron that has a blue plastic tip on the end. They say it's implant safe. If you guys have those, throw them out. I've seen them shred into the sulcus with the endoscope. The plastic comes right off the second that you touch the threads. Another popular implant tip is called Peak, but it is very thick. So this is a comparison of Acteon's implant tip compared to the Peak tip. And this is a side-by-side video of them with the endoscope. So you can see on the right is that Peak tip. It is so wide and those implant threads are very, very skinny. So this is just a video of me moving it. You can see the threads in the image, and there is no way that I'm getting anything off with that. The Peak tips are really good for a patient that has perimucositis, and maybe you're just cleaning like around the abutment, but if you have to go into the threads, you want to use something that's much skinnier. And then this is just a picture of the Acteon tip. You can see I'm really able, like you can see the size comparison I'm able to get in those threads. So piezo is more technique sensitive. I feel like piezos have a bad rep in dentistry. We're not really taught it in school. I learned it for about a day, but you have greater precision and control in deeper areas. The calculus comes off so much easier. It's less heat, which is less water, so it makes it more comfortable for the patient. And ergonomically, it's more comfortable for the clinician as well. So I'm so big when I teach my students, I'm so big on this. So many of us do wide strokes when we use the ultrasonic, but deliberate micro movements are so important. It's amazing how fine you have to make your strokes to get the calculus off. So what you see, I know I showed you a video already, but you'll always see the tip of the explorer. It's like a metal triangle. It's pulling the tissue out of the way. You'll see the sulcus. You'll always see some gum tissue. You'll see calculus. And then the CEJ is what I use kind of as like my reference point to know if I'm deep enough in the pocket or not. And then you'll always see the ultrasonic as well. So this is a video of me using it around an implant. So you can see on the left, there's a metal triangle. That's the tip of the explorer. And then I'm breaking off that calculus kind of right around the abutment. And then eventually you'll be able to see the threads there. But it's amazing what could develop around an implant. And you can see the crown of the implant, the abutment, and then the threads below it. This case was very inflamed, so the water looks a little bit like murky here, and that's just because I'm breaking off all that calculus and it's getting mixed in with the water. But now you can see the threads. So you can see if you were to go in here blindly, it would be very difficult to remove. And this was just a cement case. This patient had implants placed by an oral surgeon and she was having gum discomfort. He told her that she had to get these implants extracted, so she came to us for a second opinion. I cleaned out the cement and then she was able to get a crown on number 18. And you can see there was a huge defect on the distal of 18 that filled in. There was no laser, no biologics to use here. I just cleaned the cement out. And this is what it looks like on a natural tooth. So that brown is calculus, and you can see I'm watching myself remove it. You can see very short strokes. And this is what a root fracture looks like. So when I see root fractures with the endoscope, they're always vertical. Sometimes you can see horizontal root fractures on an x-ray, but vertical root fractures you usually can't see on an x-ray or a cone beam. And usually it's an old root canal tooth and you're going around probing and you're getting healthy numbers and all of a sudden your probe drops on an old root canal tooth. It's likely fractured, but you never know 100% unless you go in there and view the root. So you can see that crack. It's just like a line down the tooth right in the middle. So I know this all sounds great. So what do we do when the pockets don't resolve? Sometimes we'll do salivary testing, we'll do subgingival bacterial testing, blood work. Sometimes we give the patient antibiotics, and sometimes we give them probiotics. My office doesn't do salivary testing much, but when we do use the oral DNA because they have a MyPeriopath section. And sometimes we'll do paper point testing. I did have a patient once that didn't respond to laser lip surgery with the endoscope, and I was able to see that implant, so I know I got it clean. So we did paper point, and he had E. coli around that implant. So we do this to kind of figure out what bacteria is there and then what antibiotic to give them to help. And it's also to know what type, like I said, what type of antibiotic. Most offices, including mine, were using metronidazole and amoxicillin as the go-to, but sometimes there's something else going on. And then we send the patient in for blood work. So two things that are really important in periodontics are vitamin B12 and vitamin D. Vitamin D is highly linked to implant failure. Most people are vitamin D deficient and they just don't know it. So this is something that we send out to the patient's physician, and we're telling them that our mutual patient has ongoing advanced chronic inflammatory periodontitis, and we're asking them to test for these specific labs. Most patients that are going in for their regular blood work, their doctors are not testing for all of these. And I've had patients I had one patient that we treated her. She had scaling and root planing, she had laser surgery, and she still had pocketing. I went in there with the endoscope and there was not a speck of calculus. We sent her in for blood work and she had zero vitamin B12. She had to go in for infusions. So sometimes there is something else systemically going on. Not super common, but it does happen. So these are just articles. They're all recent and they're all showing how vitamin D is linked to implant failure. So blood work is really important. Not huge on probiotics, but there's a lot of talk about probiotics in dentistry, but it does help the absorption of vitamin D and vitamin K. So the realities of this, there's a massive learning curve. I don't sugarcoat that. When I train hygienists, they get so frustrated. That's why we do a 2-day training. The first day is always a lot. The second day, they feel a little bit better about it, but it takes practice. It takes about 10 to 15 full mouth cases to really feel comfortable doing it. But you can't give up on it. You just have to keep doing it. And I always say, just like how picking up a mirror in hygiene school felt awkward the first time you did that, indirect vision, all that stuff, it just becomes second nature over time. It's the only way that we do scaling and root planings and periodontal surgery. The patients love it. They appreciate the technology. Hygienists love it. And I always mention this, the hygiene department production goes up significantly. And it allows you to be compensated differently because there's a lot of stuff going on out there. I know it's happening in New York where hygienists are demanding a lot more money and the doctor's actually losing money because they